Good evening, everyone, and myself, Dr. Varun, and I am a consultant medical oncologist in Rajiv Gandhi Cancer Hospital, Rohini, in Delhi. And today we are going to discuss what is the role of mainly oral chemotherapy. Every patient want oral chemotherapy to be administered, and even any patient, like no patient want IV chemotherapy. So, what is the role of this oral chemotherapy in colorectal cancer patients? We will discuss today. And this is Tegafur Uracil versus 5U in injectable 5U. So to begin with, as a like introduction, what is the usual management options for colorectal cancer patients? We can say that chemotherapy. 1 minute. So chemotherapy remains a major therapeutic partner for this colorectal cancer patient management. Most of the patients will receive a two-drug combination. Either oral fluoropyrimidine have demonstrated non-inferiority as compared to IV 5U, and oral 5U may be combined with oxaliplatin or irinotecan. And we will discuss what will be the role of target agents to angiogenesis or anti-EGFR, and whether they can improve chemotherapy activity in these patients. So overall, like in general terms, we can say that for colorectal cancer patients, we either give Folfox or Folfiri as a chemotherapy option, in which oxaliplatin or irinotecan with 5U. So this 5U can be given either in IV form, or there is oral form also available. So, and there are option of capsaicin or Tegafur Uracil. So which we will discuss that is there any difference in efficacy or other side effect profile if we use oral options with the oxaliplatin or irinotecan, or in some old patient with some comorbidity, maybe we can't use oxaliplatin irinotecan as such. In those patients, we have to use oral chemo option only. So what about this Tegafur Uracil? This is a oral fluoropyrimidine type. So this Tegafur Uracil combines a fluoropyrimidine prodrug, that is Tegafur, and Uracil is a DPD inhibitor. And with combination of this DPD inhibitor, it allows to use as a lower dose of fluoropyrimidine by decreasing catabolism of 5U, by increasing amount of active residual 5U, by preserving 5U activity, and by decreasing side effects. So why we use DPD inhibitor with a oral fluoropyrimidine prodrug, Tegafur? Because we don't want like drug to be catabolized in intestine only, or before coming to circulation, it can catabolize in intestine and in liver. We don't want that. So with the use of this DPD inhibitor, we decrease this catabolism of 5U, and so that we can increase the amount of active residual 5U in circulation, and we can preserve 5U activity with the use of DPD inhibitor with Tegafur. And overall, this can decrease side effects. So today's topic is monotherapy. We can use monotherapy in metastatic advanced colorectal cancer patients, especially in older patients with significant comorbidities, where we can't use IV chemotherapy, or we can't use doublet or triplet chemotherapy with oxaliplatin and irinotecan. So if we talk about stage 2 and 3 colorectal cancer, there is one phase 3 trial in which Tegafur Uracil and leucovorin versus 5U injection plus leucovorin in Roswell Park regime, that is bolus regime, have been tried, have been analyzed in this phase 1 trial. And there are two phase 3 trials, that is 011 and 012, which have been done in 2002 in metastatic colorectal cancer patients. So in stage 2 and 3, phase 1, there is phase 3 trial, one phase 3 trial, and metastatic colorectal cancer patients, there are two phase 3 trials. And they have tried in stage 2 and 3 versus Roswell Park, this oral option, and in metastatic colorectal cancer patients, oral option versus Mayo's protocol. So in stage 2-3, oral Uracil and Tegafur plus leucovorin have been compared with IV 5U and leucovorin in stage 2 and 3 carcinoma colon. And this is a National Surgical Adjuvant Breast and Bowel Project NSABP study, protocol C06. And what were the results? This study has been published in Journal of Clinical Oncology in 2006. Primary aim of this study was to compare relative efficacy of oral Uracil and Tegafur plus leucovorin with the efficacy of weekly intravenous 5-FU plus leucovorin in prolonging disease-free survival and overall survival after primary surgery for colon carcinoma. And in this study, they have recruited patients from February 1997 till March 1999. It is like they have recruited for 2 years. Around 1,600 patients have been taken for analysis, and in which adjuvant Tegafur Uracil plus leucovorin have been given versus IV 5 leucovorin in Roswell protocol. So in Dukes B and C, and we may say in stage 2 and 3, around 1,600 patients have been taken, and out of which around 50% patients were in Duke B and around 50% patients in Duke C. They have randomized in Roswell regime for 24 weeks, that is weekly 5-FU leucovorin, 6 of 8-week regime versus Tegafur and leucovorin day 1 to 28, Q5 weekly, and they have given this oral regime for 25 weeks. Primary endpoint for this study was overall survival. So results of that study was that of total patients, 47% patient was stage 2. I have just shown you in previous slide. 53 patients were of stage 3. Median follow-up time was 62 months. Estimated hazard ratio for overall survival of patient who received Tegafur Uracil, that is oral monotherapy, versus that of patient who received 5-FU leucovorin IV was 1.014. So estimated hazard ratio for disease-free survival was also 1, and Cox proportional hazard model analysis with regard to age, stage, and number of involved nodes revealed no interaction with OS or DFS. So we may say that this oral option is non-inferior, or may say equal to IV chemotherapy in terms of OS and DFS, even with subgroup analysis regarding age of the patient, stage, and number of involved nodes. So we can see here that overall survival and in stage 2 and 3 is there is no difference with oral option versus IV option. And what about toxicity? Toxicity is also similar in two groups. In the Tegafur Uracil arm, 38% patients experienced any grade 3-4 toxic events compared to 37% patient in 5-FU leucovorin IV option. So primary quality of life endpoint did not differ between two regimes, although convenience of care analysis favored Tegafur Uracil plus leucovorin. As I told you before starting this presentation, that any patient want like chemotherapy to be given in oral form because that is comfortable with them. They don't have to come in hospital again and again. They don't have to need admission. Just take oral option, oral drug at home at their convenience. And on the top of that, if toxicity profile are also similar, and if results are also similar in the form of overall response rates and survival data, so then what is the harm of using this oral option? We should go ahead with oral chemotherapy only, because that improves quality of life over patients. Okay, so we can conclude with this NICDP study that oral Uracil, Tegafur, and leucovorin achieved similar TFS and OS when compared to intravenous weekly bolus 5-FU leucovorin regime, and two regimes were equitoxic and generally well tolerated. So in stage 3, another study of oral Tegafur Uracil as a maintenance therapy following IV 5-FU in stage 3 patient. In this study, they have evaluated is there any impact on disease-free survival of adding oral Tegafur Uracil to IV 5-FU at surgical adjuvant chemotherapy for stage 2-3 colon cancer. This study has been published in Hepatogastroenterology in 2012. They have taken 47 patients, and these 47 patients will be treated with 6 cycles of 5-FU leucovorin in as a MIOS protocol, and other 101 patients were treated with same above regime, followed by additional 12 cycles of Tegafur Uracil plus leucovorin for 28 days with a 7-day rest period. So in this study, they have given IV chemotherapy to all patients. After that, 100 patients, they have taken oral chemotherapy followed by IV chemotherapy, and they want to devise if there is any extra benefit with the use of longer chemotherapy with the oral chemotherapy option. So they have shown in their results that median follow-up time for this study was 65 months, and mean age was around 58 around 60 months, 60 years. So for all study subjects and stage 2 patients, 3-year DFS rate were not significantly different between two groups. However, For stage 3 patients, 3-year DFS rate was 80% and 60.7% in 5-fluid leucovorin, followed by UFT versus only 5-fluid IV option. And hazard ratio is 0.32, p-value is statistically significant. So based on this study, we can see here that in stage 2 and 3 in adjuvant setting, in stage 2 we can just give IV chemotherapy for a period of 6 cycles in the form of 5-fluid and leucovorin. There is no need of further chemotherapy in the form of oral option. But in stage 3, if we give oral chemotherapy like Tegafur Uracil after completion of IV regime, then it will improve DFS and survivals in the tune of 70%. And this is very statistically significant. So disease-free survival of all study group versus stage 2 patient versus stage 3 patient, we can see these Kaplan-Meier plots. So if we see that this is 5-2 group and this is 5-2 followed by UFT group, we can say this is IV only chemotherapy, this is IV followed by oral chemotherapy. So there is these graphs meet here, so p-value is not significant and survival is not different, disease-free survival is not different, we can see here. But if we do subgroup analysis of all these patients in stage 2 and stage 3, then we can see that in stage 2, p-value is 0.67, but in stage 3, it is 0.02. So it will be better if we use adjuvant chemotherapy for a longer time in stage 3 patients, because obviously stage 3 patient is higher, there is more chance of recurrence and more chance of metastasis and systemic metastasis, and so these patients will be benefited if we use chemotherapy for a longer time in adjuvant setting. And so what we can do after 6 months of IV chemotherapy, we can continue with oral chemotherapy. That will be better for patients' quality of life also. We can't do IV chemotherapy for this much long time. So, and similarly for survival of all study group versus stage 2 and stage 3, here also you can see this is OS and this is disease-free survival. So here also p-value is 0.09, that is not significant, but and in stage 2 also it is not significant, but in stage 3 it is almost significant, 0.07, and difference is huge, and this difference is usually maintained after a period of time. So we can say that addition of Tegafur Uracil to 5-fluid was found that significantly improved DFS, especially in patients with stage 3 colon cancer if we use in adjuvant setting. So there is one burning question which everyone asks, that if a patient develop some cardiotoxicity with 5-fluid infusion, or if patient already have some cardiac morbidity, whether we can use capecitabine to these patients, whether capecitabine have similar cardiotoxicity to 5-fluid infusion or not, because we are giving it as a metronomic therapy, so it may be associated with similar cardiotoxicity. So whether we can use oral chemo if patient develops some cardiotoxicity with the IV chemo. So so to answer this, we can say that this is the evidence, and they have published this evidence in Clinical of Colorectal Cancer in 2013. So they have published that cardiotoxicity is a potentially lethal complication of 5-fluid infusion. It may be a complication of capecitabine treatment, and so what should be the alternative option then? Because if patient develops cardiotoxicity with 5-fluid and capecitabine also have similar complications, then possible alternative treatment option to be considered in these patients is to replace capecitabine or IV 5-fluid by a 5-fluid surgery, that is Uracil Tegafur. Okay. So patient with advanced colorectal cancer patients and fluoropyrimidine-induced cardiotoxicity can be treated with other non-5-fluid related chemotherapy, either as a single agent, combined, or in combination with biological agents. So there are two options with us now. Patient had developed cardiotoxicity with 5-fluid, so he will develop cardiotoxicity to capecitabine also. So whether we can just omit 5-fluid, we can just give single agent or Uracil or combination of or Uracil, and we can combine some biological agents. Otherwise, we can give bolus 5-fluid, or we can give Uracil to these patients to combat this cardiotoxicity. So what about Uracil? Uracil is a natural substrate for DVT, and it competes with 5-fluid for this enzyme, reducing the degradation of 5-fluid, which is toxic metabolites, that is F-valent F-citrate. We already know that this is this is a mechanism action of Uracil. It is a DPD inhibitor. So in animal experience, by adding uracil to Tegafur, this has shown clearly that this reduces cardiotoxicity if we compare with Tegafur alone. Because in capsaicin we are giving just 5U in oral form. In uracil we are giving uracil also. That is a DPD inhibitor, and because of this addition of uracil, this Tegafur doesn't cause cardiotoxicity. So angina pectoris, arrhythmia, CHF, MI, and cardiac arrest all are reported less frequently in the tune of even less than 1% with UFT if we compare with study. So this was about side effect. Obviously, we are going to use for a long time oral chemotherapy or IV chemotherapy in adjuvant setting. So if there are any deadly side effects, we discuss about that also. So because of that, we have discussed there. Now coming to metastatic colorectal cancer patient in first time. So there were studies in this setting also. First one is study 1-1, that is Dullard J published in 2002, and Carmichael J have published in 2002. Same year, study 011 and study 012. What they have what they have do, they have compared Tegafur uracil versus 5-FU leucovorin, and similarly in the second study also. So about first, we will discuss in two summary that first study, Doeward et al. Study was phase 3 study. It was designed to demonstrate equivalence in survival of oral uracil Tegafur and oral leucovorin, intravenous fluoropyrimidine, fluorouracil and leucovorin. So this study was of non-inferiority trial. That they just want to show that this oral option is not inferior; it is almost equivalent to IV option. And in first-line metastatic colorectal cancer patients, and they also compared safety of toxicity profile also of the options. So they have stratified their patients on the terms of measurability, so that RECIST 1.1 can be applied, and we can see response rate. In the terms of performance status, they usually have taken patients of 0 to 1 performance status only, ECOG 0 or 1. Whether patient have received some adjuvant therapy and when, because in the metastatic setting, these patients should be in the first line only. And what is the which institution? This is multi-institutional study, and what is their physician choice options usually what they give in the first line. On the basis of this, they have certified their patient and they have randomized their patient into oral arm versus IV arm. In oral group, they have given Tegafur uracil in the dose of 10 milligrams per day for 20 days, and leucovorin 75 milligram per day for 20 days in 5 weeks cycle. So 4 weeks on, 1 week off, and like they have compared with IV regime of 5-FU for 25 milligram per meter square per day for into 5 days, and leucovorin 20 milligram per day for 5 days MIOS regime for Q4 week. So they have shown that oral option produced survival comparable to IV option. Median survival was 12.4 months with oral option, that is Tegafur uracil, versus 13.4 months with IV option. So numerically, it is 12.4 versus 3.4 months. 1 month difference only. The ratio for survival is 0.964, which is almost equal. It supports equal survival, and overall responses did not differ between these two arms. With oral option, it is 11.7%, with the IV option, it is 14.5%. Here also, it is not significant. So in terms of the response rates, in terms of survival and hazard ratio survival, both options, oral versus IV, is similar. We can see Kaplan here also, and these are that oral option is non-inferior in terms of response and survival when compared to IV bolus regime, that is MIOS. So median time to progression favored IV leucovorin. Oral option was 3.5 months versus IV option is 3.8 months. But tumor assessment schedule is different between these two arms, because we have assessed this option after 5 weeks, but in IV option we have assessed every 4 weeks, because cycle was of different duration. So oral uracil Tegafur leucovorin significantly improved safety compared to 5 leucovorin. And what were the difference? Diarrhea, nausea, vomiting, stomatitis, mucositis. All these side effects were significantly less frequent with oral uracil Tegafur leucovorin, as was myelosuppression. So all side effects, we may say mucositis, diarrhea, and stomatitis and myelosuppression all were less with option but IV option. And patient with the oral option, oral Uracil Tegafur, had fewer episodes of fibroneutropenia because there were less myelosuppression episodes, so less fibroneutropenia, and documented infection also less. So all these side effects are less with oral option, and PFS and OS and the response rates are similar. So obviously, in that case, we should use oral option only. So point to be noted that in metastatic first line, as standard of care is doublet of therapy. That is with use of oxaliplatin and inotinib 5 so this study will be applicable to those patients in which we can't use oxali or in view of performance status or some comorbidities or some previous reaction to the agents or maybe like frail patient, maybe old patient. So in that case, if we are going to use only 5-methylcobalamin, then this study will be applicable. So in those patients, we can use oral option, obviously, in because IV option survival and response rates are same, while side effects are more. What about this Carmichael study? Same year publication, and this is also phase 3 study, and they have compared time to progression of oral option versus IV option. And they have given Tegafur Uracil in a 1:4 molar ratio with leucovorin, and they have taken patients which have been previously untreated with a study patient as in the previous study, and their endpoints were survival, response, safety, and quality. Primary endpoint was time to tumor progression. Second endpoint were PFS and OS, tumor response rates, and quality of life and toxicity profile. So they also have certified their patient according to performance status prior to therapy and institution, and given same dose, 300 milligram per 28 days, and leucovorin 90 milligram per day, 28 days in 5-week cycle, and IV option is also same as in the previous study. So they have shown that there is no statistically significant difference in time to tumor progression was observed between these options, arms, with 320 events assessed. Median time to tumor progression was 3.4 months versus 3.3 months. 3.4 months in oral Tegafur leucovorin and 3.3 months in 5-week leucovorin IV option. And p-value is 0.591, and that is not statistically significant. So both the treatment arm are same in terms of time to tumor progression. And similarly, they have shown that there is no statistical difference if in other parameters also. Same survivals, PFS and OS, same response rates, and duration of response and time to response, all things are same. But where is the difference? Substantial safety benefit was observed with patients who have been treated with Tegafur leucovorin. They experience significantly less stomatitis, mucositis, and myelosuppression, which is resulting in episode of fibroneutropenia and less documented infection. So concomitant medication usage was significantly greater with 5-leucovorin because there is more side effects, so more supportive medicines with the IV option, less side effects, so more less fibroneutropenia and less infections. So with respect to quality of life, because obviously more medicines and more side effects, so less quality of life. So if we compare according to quality of life, there were no significant difference between treatment for any scale except diarrhea, but overall less side effect in oral chemotherapy option. So based on these two studies, as such, study to study can't be compared, but just to summarize here, in first study, number of patients was 800, in second study around 400, and objective response rates with oral chemotherapy 11.7% and 10.5% versus IV chemotherapy 14.5% and 9%. So in this slightly increase, in this almost same or slightly decrease. So median time to progression is 3.5 and 3.4 months with oral, and IV 3.8 and 3.3 months. And overall survival is 10.4 and 12.2 months, around 12 months with the oral, and around 13 months in this study, and around 10 months only in this study. So overall, this p-value is significant if we talk about this side effect profile. But if we see this overall response rate, time to tumor progression, PFS, OS, all are almost same with the oral and IV options. So now coming to next options, like that is in what about survival? Same control regime, myoclinic regime, have been given in both the studies. Different timing of retreatment but similar dose intensity and survival endpoint. So can we combine these two studies and then can do like combined results? So if we combine these two studies, then total number of patients will be around 1200, and we can say that hazard ratio is 1. So even after combining these studies, obviously results were almost similar. We can see that both the option oral and IV are same in terms of survivals and response rates and side effects, side effects. So this oral option is associated with less myelosuppression and less other non-hematological side effects like mucositis and Hanford syndrome, while IV option is associated with more side effects. If we particularly talk about Hanford syndrome, we can see that any Hanford syndrome is 7 patients with oral chemo, that is 2%, while 5% with IV chemo in this study 011. While in 012 study, no patient had developed Hanford syndrome with Tegafur Uracil oral. And this is about concomitant medications, because obviously if patient develops side effects, then we have to give more supportive care medicines like antidiarrheal medicine, antiemetic medications, and anxiolytic medications, growth factors in view of myelosuppression. All these like concomitant medications have to be given more in IV chemotherapy options. So overall, we can say that this Tegafur, Uracil, and Leucovorin as an initial treatment for metastatic colorectal cancer patients produces equivalent survival for 5 and Leucovorin, clinically significantly safety advantage, and reduction in myelosuppression, fibrinolympopenia, infection, stomatitis, diarrhea, and concomitant use. And as I've told you like many times, that patient obviously prefer for oral therapy only. So patient prefer Tegafur Uracil to IV bolus in a randomized crossover trial in advanced metastatic colorectal cancer patients. And obviously if there is an option of crossover from oral to IV or IV to oral, then most of the patients have gone from IV to oral arm. And patient choose to continue treatment with Tegafur Uracil versus IV 5. So in terms of numbers, we can see that Tegafur Uracil was preferred by 84% patients at the end of the therapy, because what are the reasons? Medications can be taken at home with convenience, no painful sores in the mouth, less side effect, it doesn't cause diarrhea, it is a pill only, and there is no interference with daily activities. So it improves quality of life. And it also saves resources. It also is more friendly with pocket. Obviously, less costly. There is no like less expenditure on supportive care medicines, less expenditure in view of less hospitalization because less fibrinolympopenia. So obviously, that is also going to be noted and going to be, and for that reason also oral option is better. So less resource used for Tegafur Uracil with Leucovorin, and key reason for hospitalization was for treatment of adverse event. If we see in Tegafur Uracil was only 21%, while in IV5 it is 36%. So equivalent survival with Tegafur Uracil versus IV. Improved safety profile of Tegafur Uracil, significantly less diarrhea, nausea, vomiting, stomatitis, mucositis, and myelosuppression, less use of concomitant medication, and preferred by patients. So to conclude, we can say that Tegafur Uracil is an orally active prodrug of 5-FU with activity in. If we see both alone and in combination of oxaliplatin. So it is not like that this drug will not work in combination of oxaliplatin and irinotecan. We have shown studies where we have compared 5-FU versus 5-FU. Like route of administration is different. We have compared IV versus oral 5-FU. If we want to add oxaliplatin or irinotecan, obviously we can give this Tegafur Uracil in the form of Tegos or Tegri, and there will be no problem. So Hanford syndrome is very rare with Tegafur Uracil, and future metastatic colorectal cancer patient treatment will include targeted therapy like Erbitux with the combination of Tegafur Uracil plus irinotecan or oxaliplatin. As we can add irinotecan or oxaliplatin with this Tegafur, we can also add Erbitux or bevacizumab with this. So few slides about adjuvant Tegafur Uracil in stage 3 colorectal cancer patients. This is a final results of JCOG 0205 study, have published in 2014. They have done this study in between 2003 to 2006, in between around 2.5 years, and they have taken around 1,000 patients, have randomized to 5 Leucovorin or Tegafur Uracil. Median age in this study was 61 years, and around if we see number of positive nodes less than 3 or more than 3, so most of the patients, around 75% patients, were with either 1 or 2 or maximum 3 lymph nodes, and 27% patients with more than 3 lymph nodes. And stage 3A, 3B. So obviously, based on this number of lymph nodes, we can say that stage 3A is 75% patients, and stage 3B 25% patients. So they have found that hazard ratio for DFS was 1.02. So what was their assess study was adjuvant chemotherapy with oral Uracil and Tegafur plus leucovorin versus IV-5 and leucovorin in patients with stage 3 colorectal cancer patients who have undergone Japanese D2, D3 lymph node dissection. So here catch is that we have done already lymph node dissection D2, D3, and we have done subgroup analysis and stratification based on the number of lymph nodes, like less than 3 or more than 3 in stage 3 patients. So is there any difference if we use oral versus IV chemotherapy at a given setting in these patients? So they have shown that hazard ratio for disease-free survival was 1, demonstrating the non-inferiority of oral option. 5 years of survival was higher than in the NSABP C06. So overall, in this study, they have shown that 5-year-old survival is 87% versus 69%. Maybe because they have done extensive lymph node dissection with the cells. Grade 3 for toxicity was 8.4% neutropenia in 5-leucovorin and 8.7% increase ALT, AST in Tegafur. So more number of myelosuppression in IV, more number of LFT derangement in terms of increased AST, ALT in oral Tegafur. So incidence of diarrhea and anorexia were similar in both arms, and no treatment-related death have been reported in this study. So they have interpreted that adjuvant Tegafur Uracil leucovorin is non-inferior to standard 5-leucovorin in respect to DFS. Tegafur Uracil leucovorin should be an oral treatment option for patients with stage 3 colon cancer who have undergone Japanese D2, D3 lymph node dissection. So these are various studies in various settings, like in adjuvant setting, stage 2, stage 3, with extensive surgery or without extensive surgery. In first line metastatic setting, in all we have seen that if we compare 5U in terms of IV or oral, then it is similar in terms of responses and survivals. But what about guidelines? What guidelines recommend about Tegafur Uracil? So according to NICE guidelines, capecitabine and Tegafur with Uracil oral therapy with either capecitabine or Tegafur Uracil in combination with folic acid is recommended as an option for first-line treatment of metastatic colorectal cancer. So according to NICE guidelines, these oral options are well indicated. And overall consensus, we can say that especially in older patient with comorbidities with some side effects already have, and patient preference, we can switch IV to oral 5U in the terms of capecitabine or Tegafur Uracil. And if there are any cardiotoxicity, then we can give UFT, like we can't give capecitabine in those patients. So according to Japanese guidelines, this UFT leucovorin with bevacizumab is the treatment option for these colorectal cancer patients, and especially if patient is appropriate for intensive therapy, and even if patient is not appropriate for intensive therapy, even then we can give this combination. So according to NICE guidelines on the use of capecitabine and Tegafur with Uracil for metastatic colorectal cancer, recommended dose for Tegafur and Uracil is Tegafur 300 mg per meter square, as was the dose in most of the trials using Tegafur, with Uracil in the dose of 672 mg per meter square daily, combined with oral folic acid 90 mg per day, given in 3 divided doses, preferably every 8 hours for 28 days. So it is like usually this UFT tablet, 3 tablet morning, 3 tablet evening, and this Vivarin tablet 30 mg days, and this to be continued for 28 days, then 1 week rest, and then again next cycle. So subsequent course are repeated at 7-day interval, giving a treatment cycle of 35 days. So coming to few slides regarding is there any role of Tegafur Uracil in concurrent chemoradiation therapy. CCRT is widely used in the treatment of solid tumors. We know about that, and in almost all malignancies in which local regional control is necessary, CCRT is an established treatment modality or is actively being investigated. So this CCRT is highly efficacious local regional treatment option for solid tumors, which can be used alone or combined with surgery or induction consideration therapy. So what are the various clinical rationale? So and these are like general principle. We can't say that CCR because we know that CCRT is not usually recommended for rectal cancer patients, but maybe especially in rectal cancer patients. So what is the rationale? CCRT can be used for organ preserving intent, resulting in improved prosthesis and function compared with surgical extraction with or without regimen treatment. Here, what is the role of chemotherapy? Chemotherapy usually acts as a reduced sensitizer. It improves the probability of local control and survival by aiding the destruction of reduced resistance clones. So chemotherapy given as a part of concurrent chemoradiation may act systematically also and potentially eradicate distant macrometastasis. So this is like general rule we all know. This is like a basic principle. So just to emphasize that in radiation is for local treatment, and we give chemotherapy to enhance the effect of radiation as a sensitizer and also to eradicate distant macrometastasis, because this is a systemic treatment. It may act in systemic also. So other mechanism for certain property, we can increase radiation dose, but that may be should with more side effect, and we can inhibit DNA repair. We can give some drug to cause cell cycle synchronization. In terms of like for cell cycle synchronization, we can change fraction duration. We can give per day 2 fraction, and at 2 different times as compared to single fraction. Increase cytotoxicity against hypoxic cells, so that is another mechanism to increase reduce sensitizing properties, inhibition of survival pathway, and abrogation of rapid tumor cell recuperation. So about these are should be discussed in detail, but this is not and the purview of today's discussion. We will discuss some other time. So coming to rectal and anal cancers, so here especially the role of CCRT in rectal and anal cancer. So CCRT has improved the management of rectal cancers. In many patients, it is performed after surgery, but in some patients, CCRT followed by surgery is also an option. So if we use CCRT after surgery, it allows pathological staging, and results of standard surgery and post-chemotherapy therapy show a statistically significant reduction of local recurrence and improve of survival rate. Okay. So obviously there is some pro and cons. Some school of thoughts is that chemoradiation should be given before surgery, and some says that it should be given after surgery. So there are some pro and cons for that, both the options, both the plans. So overall, we should use CCRT either before or after surgery, because it causes significantly improvement and reduction in local recurrence and improvement of survival. So coming to evidence, like in stage 2 and 3 rectal cancer, study published in Anti-Cancer Research in 2006, there was study that was post-operative concurrent chemoradiation therapy using oral Uracil Tegafur versus weekly intravenous biopsy for locally advanced rectal cancer. This was a prospective randomized study. It was to compare efficacy and toxicity of post-operative concurrent chemoradiation therapy using daily oral Uracil Tegafur plus Lupin versus weekly intravenous biopsy plus Lupin. So this study was first to confirm the effectivity of concurrent chemotherapy with radiation, and that is all the more with oral option, that is Uracil Tegafur plus Lupin. So they have taken 30 patients with stage 2 and 3 rectal cancer patients, and they have divided patients in IV versus oral group. In IV option, they have given 5U, 4 to 450 mg per meter square, plus 80 to 100 mg per meter square weekly with radiation, versus oral UFT, this Tegafur Uracil plus oral leucovorin per day. So radiation was given in the dose of 50.4 to 60.4 gray. It was delivered to the tumor bed in 28 to 33 fractions. So what was the results of this study? Mean survival was 36 months versus 30 months. 2-year overall survival was 68% versus 66%. On disease-free survival was 5% versus 50%. So here, disease-free survival p-value was statistically significant. Difference is 55 to 50%. But otherwise, 2-year survival rate is almost same, and mean survival is 36 versus 30. So overall, there was no treatment-related death or grade 4 toxicity in either group have been seen. some grade 3 dermatitis, gastrointestinal hepatotoxicities were noted with IV. 2-year overall survival curve, if we see with IV versus oral, so these curves cross each other. So we can say that survival is not different in between these two groups. And similarly, 2-year disease-free survival curves also crossing each other. And 2-year local regional control curve is like this. 2-year metastatic-free survival curve is like this. So because of its similar survival rate and lower toxicity, oral uracil leucovorin is suggested as an alternative regime to IV 5 leucovorin in post-operative if we are giving the concurrent radiation for locally advanced rectal cancer patients. So with this, thank you. I hope I have covered oral chemotherapy options as immunotherapy and combination therapy in all the settings in colon cancer and rectal cancer, in colon cancer adjuvant setting and metastatic setting. And there was one study I have discussed about IV followed by oral option, and even in rectal cancer patient, what is the role of oral chemotherapy with radiation. So I hope I have covered all the things. And is there any doubt? If there are any queries, I am here to clear that. So any query, any questions?
Sir, there are no questions as of now on the platform.
Okay. So anything to add from your side, Jagdeep? From Lupin side, anything to add?
Sir, that's fine. That's fine.
Okay. So in that case, thank you, Lupin, for giving this platform. And I can in that I can share my experience and various literature and evidences about the use of oral leucovorin Tegafur use in colorectal cancer patients. And thank you, Lupin, and thank you all the participants for patience hearing. And I will be looking forward for these type of interactions in the future also. Thank you.
So from Lupin side also, we thank you a lot for giving us this opportunity to arrange this scientific session. And so looking forward to working with you once again. And thanks a lot all the audience for joining in. Thank you so much. Thank you, sir, once again.
Okay, thank you. Bye-bye. Good night.
Bye.
Lalit sir, we can end this meeting now.
Yes, right.
Okay, sir.
Okay, bye-bye.
Bye, sir.
Bye, sir. Take care.